Well, welcome everyone. We're delighted that you can join us via Zoom and this esteemed panel. We're very excited for a presentation on treatment options for early stage breast cancer. Joining us are Dr. Peter Schulz, surgeon, Dr. Iliana Popescu, medical oncologist, and Dr. Vasudha Lingareddy, radiation oncologist. I'm Allison Mayer Sachs. I'm Director of Community Outreach and Cancer Support Services, and I am a certified oncology social worker. Before we get into our informal discussion, Q&A with all of you will be at the end of our discussion. You have a Q&A portion in your bottom of your screen, most of you. Just put your questions in there. And Heather Van Meetren, our coordinator, is here, and Heather will read them out for our physicians. So if everyone is ready, thank you again. I do want to point out to all of you, in the middle of a very busy work week and time in the desert, our physicians always say yes. They take the time because they're dedicated and they know that an educated patient is the best patient to be part of their healthcare team. So thank you all for joining us. I really do appreciate it.
Yeah.
I thought we might start, Dr. Popescu, with you and questions about breast cancer and the diagnosis of breast cancer. I mean, for me, when I was thinking about this and speaking to patients I work with, one of the first questions I always hear from them is, how do I know what type of breast cancer I have, doctor? And how did I get that? No one in my family ever had breast cancer. So where do we start?
Those are a lot of questions altogether.
Sorry.
Yeah. So how do you know what kind of breast cancer you have? Basically, the biopsy people get, that tells the whole story, what kind of cancer it is, how you treat that cancer, what steps do you do in the treatment. So that makes a lot of difference. Not everybody gets the same treatment. It's very rare when people have a type of breast cancer, you can actually think about it, meaning the breast looks different. Bright red, it's called inflammatory breast cancer. That it's becoming very rare.
Mm-hmm.
Other than that, there is a subtype of breast disease where the nipple looks different, meaning could be also red, could be scaly. People can have a breast discharge. That also is not very common. Comes to mind something called Paget's disease that can look like that. It's only 1 to 3% of all breast malignancy conditions. So most of the breast cancer, because of the technology nowadays, they are found early. And basically, how do we find them is the breast imaging, the mammograms, and all the other modalities you heard in other lectures, ultrasound, MRI, physical exam. It's always important. People forget about that quite a bit. And then, of course, once there is a suspicion for cancer, it does require a biopsy. There is no way going around that. Some patients do ask about it. Well, why do I need a biopsy? Why don't I get surgery? So biopsy is necessary, first of all, to know what kind of surgery you get, what kind of treatment you get, and when. You don't always get surgery first. Certain cancers require different treatments first.
Right.
So that's the whole idea. Now, why someone gets breast cancer, that's also a loaded question.
Sorry about that.
But then there are risk factors. And the number one is being a woman. So you can't really change a whole lot about the DNA. However, there are men with breast cancer as well. Those are 0.5 to 1%, depends on what you're reading, of all the cases. There are other risk factors such as age. And again, we can't do too much about that either. The average age nowadays is reported at 61. That's not to say younger people can get breast cancer or older people cannot. The other major factor in my mind, this century would be obesity, the weight, the lifestyle factors. I was reading the other day something nobody talks about anymore, at least here, about smoking.
Mhm.
And actually, there is a correlation with breast cancer. There are fewer people smoking nowadays, that's true. But smoking, it's a factor, and particularly if people continue to smoke after breast cancer diagnosis, it's worsening the prognosis. And there is actually a statistic about that
Right.
recently.
And I've heard too,
Yeah.
thank you for that, for the lifestyle changes. And we will circle back about treatment options that come from you, from our medical oncologists, but also with the environmental or lifestyle factors. I've been reading more and more, to my chagrin, to be honest, because I like my glass of wine,
Yes.
that alcohol can be a contributing factor now to, at least it's a statistical risk. It doesn't mean if you drink, you're going to get breast cancer, but it ups your risk of possibly developing.
Yes, it does. And particularly for breast cancer survivors, because these are the people eventually I'm talking to, it is an issue. And sometimes I get this looks back, what do you mean if I drink one glass is more is too much? So it's basically one glass of alcohol a day. More than that is too much for a woman. Men get
Little
a break.
more.
Yeah.
And
Other issues, the hormone replacement,
Yeah.
that's still
Yes.
a factor. People forget about it. But yes, it is a risk factor, and it stayed like that.
Right.
That didn't change.
Right.
So
So if you heard clearly, I think that's important. I know that I'm listening, certainly. Our weight, exercise, what we're eating, alcohol. Well, we'd rather you didn't drink at all. If you're going to drink, for women, it's one glass. I believe it's 4 ounces a day. Now, here's the thing. You may not save that up and drink it all on Saturday night. That's not the rule, not allowed. So thank you for that, Dr. Popescu. That's so helpful. You mentioned biopsy, and we have our incredible surgeon, Dr. Peter Schulz, here with us. Dr. Schulz, so, okay, woman has her mammogram, she's screened, there's something seen, they're called for a biopsy. My office happens to be down the hall, so I hear a lot that goes on in our breast center. And one of the things that confused me is I'll hear, well, we'll schedule your biopsy here with our radiologist. But then I'll sometimes hear, well, you need a surgical biopsy and we're going to have that done over at the hospital. What's the difference and why?
So a biopsy can be a confusing term. And in the first part of making a diagnosis, a tissue diagnosis of breast cancer, a biopsy is done by a radiologist, and that biopsy can be done using ultrasound guidance if the mass or the tumor is amenable to ultrasound biopsy, or sometimes it's only seen on mammogram, and the mammogram machine is then used to do the biopsy. That's called a stereotactic biopsy. And sometimes an MRI machine has to be used in order to get a biopsy done because it's not well seen on mammogram or on ultrasound. Those biopsies, perhaps the best term to explain that is it's a sample. It's really a portion of, because then the patient may get referred to a surgeon, and we're also doing a biopsy, but it's really an excisional biopsy at that point. So most of the biopsies that are done to diagnose the breast cancer is a sample biopsy, and it's most often done using what's called a core needle. And that needle has a large piece of tissue that is taken out, not spray cytology, but actually a drill of tissue so that there's ample tissue to make a diagnosis. That's called a breast biopsy. And then surgeons do biopsies, but most of the time they do excisional biopsies. And so I hope that clarifies the term biopsy.
It does. Thank you very much. And then that biopsy goes to the lab and where it's looked at and determined, that's where they can say it's this type. Dr. Popescu, how many types of breast cancer are there?
Well, I didn't count them.
Sorry about that.
But the most common one, it's called ductal carcinoma, meaning it starts in the milk ducts. That's about 80% of all the breast cancers. The second most common is called lobular breast cancer. It simply depends, to make that description, there are some special stains the pathologist does in the lab to say this is what it is, but they also look different. There are some rare types of breast cancers, and those are sometimes found in other body parts. There is a term called sarcoma that it's rare for the breast, fortunately, but could be found in other body parts. There are, the terminology is a bit different. You heard of metaplastic breast cancer. Or even among that subtype, I don't want to get too much into it, but even among that subtype, it's confusing for people. Metaplastic could actually, it's known to have a more, a worse prognosis. However, one subtype, it's called adenosquamous metaplastic, that actually has a better prognosis than other cancers. So I don't want to get too much. In the breast also, you could find lymphomas, which people may not expect, and that is treated totally different. So without a biopsy, that's why we don't recommend any treatment until we have tissue diagnosis.
So I have the tissue diagnosis, that's the biopsy. The consultation then happens with the surgeon. And I'll go back to that then Dr. Schulz. How do you know which type of surgery to do? Why, we know there's lumpectomy. We know there's mastectomy. We know there's bilateral, which means both sides. What drives that decision? I know you all work in tandem making these calls, but share a little bit with us. How you determine?
So basically, that determination is made jointly with the patient, the surgeon, and the oncology input. And the majority of cases now, thankfully, because of screening, because of education, because of widespread mammography use, most of the cancers now are found early stage, and they're highly curable. And the majority of cancers can be treated with what we call breast conservation. That means keep the breast.
Mm-hmm.
And sometimes, in addition to the lumpectomy, lymph node staging needs to be done to be sure that there isn't any microscopic escape of cancer cells into the lymph node. That's called a sentinel node biopsy. So the majority of patients can be offered breast conservation and lymph node staging, called a sentinel node biopsy. And then they get additional treatment after that when everything is properly staged by the pathologist. Then the determination of additional therapy is made. That's called adjuvant therapy or after surgery therapy. And that can include anti-estrogen treatment, sometimes chemotherapy, and often radiation treatment in addition to the surgery.
Right.
The mastectomy decision is a difficult one. It's a complex one, and it depends on the tumor size. It depends on the tumor location. It depends on relative breast size, and it depends on the diagnosis of what cell type it is and how aggressive it is. We know certain cancers have a tendency to be more frequent in the other breast, and that may impact the decision on whether or not to do lumpectomy, mastectomy, or bilateral mastectomy, with one breast being removed for therapeutic purposes and the other breast being removed for prophylactic purposes.
Meaning prevention.
Meaning prevention. So the decision to offer breast conservation, hopefully, is the most common decision, but there are many times that breast removal is indicated as preferable and would be the right choice.
So the adjuvant, again, so I understand, that's having surgery up front and then follow up with whatever the team decides the patient's needs. Is that correct? So
Yes.
what's that term neoadjuvant that I hear in tumor boards when our physicians get together and discuss cases and discuss treatment options? That's what a tumor board is. I have the pleasure of sitting in and learning from these experts. So what's neoadjuvant?
Neoadjuvant is treatment given before surgery. So that again goes back to the pathology report, to that biopsy. There are certain types of cancers where we consider chemotherapy first. For instance, what we call triple negative breast cancers. Those are hormone negative breast cancers and HER2 negative. Those are pathology features that dictate the treatment. There is another type of breast cancer, the HER2 positive breast cancer, where we many times discuss neoadjuvant therapy. The other issue, we are talking about early stage breast cancer. So we didn't say exactly what early stage is. I think that's important because most of these patients actually do well, and we are not aggressive upfront as we would be with what we call advanced breast cancer. Early stage, if we think of the stages of breast cancer, I always say there are 5 stages, 0, 1, 2, 3, 4. Stage 0 being non-invasive, where the cells didn't break to the membranes. That is truly early stage and excellent prognosis. Then early stage is stage 1 and what we call stage 2A and some 2B breast cancers. Why do we call them like that? There is an international system of staging where we decide what stage it is based on the tumor size and how many lymph nodes are involved, or sometimes the location of those lymph nodes. Everybody thinks the lymph nodes are only underarm, but there are other lymph nodes we look at. So
That's very helpful.
mhm.
So a patient is, we've been screened, we've had a biopsy as a diagnosis of breast cancer. The team has discussed both with the patient and amongst themselves whether or not there will be adjuvant or neoadjuvant, any treatment indicated. Usually it's then off to surgery. So I assume there are other tests you do before surgery, Dr. Schulz, and that helps you during your surgery. What might some of those be, or terminology that our listeners might hear? Because we hear, I don't know, I have to go for this test and I have to go for this test and my cancer's growing. Why aren't they taking me into surgery right away? Can you address that a bit for us?
So that's a really good question. And there's a plethora of preoperative exams that many patients go through before making the final determination of what surgery, how to approach it, and how to properly treat this with surgical intervention. And many patients start off with a mammogram and they have an abnormality, then they have a biopsy, a core biopsy, a sample that shows that it's cancer. And with that diagnosis, we start to look at the affected breast and the other breast with a little bit more detail.
Mhm.
So that often triggers a series of preoperative imaging that is a long wait in the patient's mind to get everything done, because once there's a diagnosis of cancer, there's an appropriate time clock that starts, and people want to have resolution of this.
Right.
But there's a lot of exams that are done that are in addition to the mammogram. Quite often we need to get an ultrasound. quite often we need additional mammograms with additional views. Quite often we will get an MRI, especially if the breast tissue is very dense. And every time a preoperative imaging exam is ordered, it may find something additional. And I call it the wait, but there's more before surgery.
Right.
And sometimes something is seen on the other side, or sometimes there's another item found in the same breast. And all of that has to be declared before surgery, because sometimes we find cancer in the same breast that's in two different remote spots. And that is called multicentric cancer. And in most cases with multicentric cancer, you go from breast conservation to requiring a mastectomy. So there's a due diligence of imaging that goes on before surgery. And then there's also the preoperative anesthetic requirements. There's a chest x-ray, there's a blood test, there's an EKG. Many of our patients are on anticoagulation and have cardiac surveillance. And we have to get a preoperative cardiac evaluation and preoperative cardiac clearance in order to have the safe anesthetic. And the anesthesiologist knows exactly what the risk factors are. So there is a process. It seems like it's always prolonged, but we do explain to patients that cancer patients have the highest priority in our practice and in our system with imaging and with scheduling. And but it's never fast enough.
Right. Right. Understood, and understand the fear that goes along with that. I've heard often all of you say that breast cancer is not growing that fast. We wouldn't be risking your life and delaying your treatment.
Right.
And to remind everyone, I certainly had to be reminded of this, that there's steps. The treatment has to go. You can't jump those steps. It's very specific to get the proper diagnosis to lead to the correct treatment.
I may add one thing though. There is also the issue of genetic testing, which we have a lot more knowledge nowadays than 20 years ago, let's say. So some patients do require genetic testing in order to be offered the proper treatment options. And that takes anywhere 2 to 3 weeks
Right.
to return. So there are also certain patients where we think the cancer is more aggressive. And sometimes we do scans to make sure the cancer didn't spread. So,
Right. Well, thank you for that.
yeah.
Sticking with surgery for just a little bit, and then I promise we're getting to radiation, Dr. Lingareddy. We are. Dr. Schulz, what's the length of stay? Can you share a little bit? I know it might be different, lumpectomy, bilateral, one-sided, but a length of stay. And, years ago, thank goodness we haven't heard that term anymore, was the drive-through mastectomy, which scared so many people. And yet we've come to find with the surgical techniques you have all honed and developed, you don't necessarily have to stay in the hospital, even overnight sometimes. Is that true?
Absolutely. So the majority of early breast cancers that are treated with lumpectomy and sentinel node biopsy are an outpatient procedure. It's very rare that they require hospital stay. And so the majority of these early cancers are basically outpatient. For breast removal with or without reconstruction, in many cases, it can be done as an outpatient. If the reconstruction is done on one side or the mastectomy is done on one side, it certainly can be considered an outpatient procedure.
Wow.
If it's both sides, it's usually one night stay. The majority of our patients that require mastectomy usually are admitted overnight for pain control, IV fluid, observation, drain management, and they're good to go the next day. That's probably the biggest percentile, but many patients, especially if the tumor is smaller and the surgery is not a prolonged operation, it can be done as an outpatient.
That's wonderful. That really is. So we've found the cancer. We've had our consult. Surgery has occurred. Dr. Popescu has weighed in on whether or not there is more treatment needed other than surgery. Certainly with certain positive breast cancers, estrogen, progesterone positive, there is an oral treatment, an aromatase inhibitor, or AI, that goes along with that. It's pretty common, it seems to me, nowadays.
Yes, but that is only for women at menopause.
Right.
It's not for what we call premenopausal women. And actually, I like to say that there is more science to it than me saying you need chemo or not chemo. And there are certain tests, they are called genomic tests, just to confuse everybody. So it's not the same thing as a genetic test. Genomic test, the more common one, it's 21 gene assay. There are other ones, but this is the more common one. And basically that requires a part of the tumor to be sent to a special lab to tell us, does this patient really needs chemotherapy or not? So if someone is chemotherapy is first, and then we decide how much, which agents, that depends a lot on who the patient is. So it's really tailored medicine. It does matter what other conditions that patient has. Do you have diabetes? Do you have heart disease? So that will tell us what treatment and for how long also. The majority of early stage cancers, though, do not require chemotherapy, but I'd like to see that test if possible. For patients that have hormone negative disease, chemotherapy many times it's indicated, and that is first before the radiation, if radiation is to be given.
Understand. And I think it's important because it is very confusing for us lay people that on the one hand, the genetics, the genes you inherit from mom and dad, looking at that, geez, it's been so many years now, the Angelina Jolie effect, she had a positive gene inherited from her mom. Her mom passed from ovarian cancer. So she in turn chose to do, there's that term, prophylactic, preventative removal of her breasts and her ovaries to prevent getting cancer at a later date. That's one thing, but the genomics, that's what you were talking about. That's that gene makeup of the cancer cell.
Yes.
Wow, that's pretty impressive. Well, thank you for that. That's important to know. So radiation treatment, Dr. Lingareddy, where does radiation treatment fit in this kind of pathway through breast cancer treatment?
So it is adjuvant after surgery. And just as Dr. Popescu said, if systemic chemotherapy is recommended, that always comes first.
Okay, good to know.
That is also based on studies that gives us the best survival doing chemotherapy first. Then the radiation after recovery, if chemotherapy is indicated, then radiation is initiated. Not every woman, of course, gets radiation.
I'd like to clear something up about radiation right away because us 60s and 70s babies remember we were diving under desks, radiation from bombs, and radiation is deadly. So what's the difference? Here we're giving radiation to kill cancer, but many of us had learned radiation can cause cancer. What's different?
So both are true. And diagnostic radiation, of course, we do get criticized for ordering too many diagnostic tests and
Yes, you do.
unnecessary. But yes, that is lower energy, lower dose, whereas therapeutic radiation is generated by a completely different machine. It's much higher energy, very focused, and it treats cancers or prevents cancers from recurring. That's not to say that therapeutic radiation, what we use in radiation oncology, can also cause cancers. And there's certain types of cancers outside of breast and also within breast. Very specific women do have an extremely small risk of developing sarcomas, which Dr. Popescu had mentioned subsequently. 8 to 10 years, but that risk is extremely small, and we don't see it in every woman.
So using that, for those of you who've never seen radiation, it's quite a machine. It's quite impressive. It's called a linear accelerator.
Correct.
And if what I understand is at least, and this is all physics based, really,
Yes.
you're developing, you're delivering pinpoint radiation, doing the best to not harm any healthy tissue around the area that we just want
That's
to
right.
kill with the radiation.
That's exactly right. It's very pinpoint. The edge of the beam is 0.2 millimeters of, but and that has been developed over decades.
Mhm.
So previous radiation 20, 30 years ago, very different than what we're delivering now.
And how many radiation treatments is there, like the standard? Well, you're coming for radiation for your breast cancer and you're going to get this.
That's a really great
Sorry.
question. I know. So that's been looked at for decades as well. We used to give 6, 7 weeks of radiation, and that has completely evolved to as short as one treatment where you put the radiation inside the breast.
Like in a capsule almost?
In a capsule and sort of a
Wow.
applicator around ball that goes inside the breast at the time of surgery, to 5 treatments or 10 treatments twice a day. That also requires catheter-based internal radiation. But the most common is external. There's nothing invasive, there's no catheter, there's nothing inside the breast. Patient lays down on a table and the machine is 100, if the radiation is coming 100 centimeters away, pinpoint to the area that needs to be treated. And that usually requires, standard used to be 25 treatments to the breast. We've now shortened that to 16,
Wow.
but the dose goes up when you get 16 treatments, 15 to 16. Then the question becomes, should we give a little extra radiation? So that's whole breast. The entire breast is treated.
Got that boost? I hear that
Yes,
term boost a lot. And I think of the stuff
exactly.
you drink, but that's not what you're talking
No,
about.
that's exactly right. So whole breast radiation would be the equivalent of what Dr. Schulz was talking about. If you do a mastectomy, of course, you're removing all of the breast tissue. With whole breast irradiation, you're radiating the whole breast. Extra 4 or 5 treatments to where the tumor used to be, or that boost, that surgical cavity is given to younger women, women whose margins are negative. They don't need more surgery, but maybe a little close. So it's a little extra treatment. Very often the dose goes down with the boost. So, and that we discuss at the time of consultation, with the patient, how much dose is needed.
And Dr. Schultz had mentioned breast reconstruction, and that sometimes that can happen at the same time as the breast, usually it's mastectomy. That the doctor might work in conjunction in the operating room with a plastic surgeon. What happens if they need radiation after that? Does
Yes,
that create issues?
it does.
Ah,
It creates tremendous issues. So usually it's not correct that every woman who gets a mastectomy then does not need radiation because her breast tissue is gone. So a lot of factors go into that. How large was the tumor prior to surgery, even prior to chemotherapy? Was there a positive lymph node that we were aware of either on imaging or on biopsy before any treatment? And so even after a mastectomy, there are indications to add radiation therapy to the chest wall and draining lymph nodes. So with reconstruction, you can either delay it, so the chest wall is flat, radiation is delivered, and once everything is healed, whether it's 6 months, a year later, then go through with reconstruction. Or sometimes an expander is placed underneath the pectoralis muscle. And there's all sorts of theories whether it should be expanded or partially expanded. And some women choose to complete their reconstruction. That delays the radiation a little bit, but complete, whether it's an implant or a
Mhm.
flap, a deep flap. So yes, the radiation does cause issues with reconstruction. There can be wound healing issues, and so that's also a lengthy discussion.
And a discussion, I assume, between all of you as
Absolutely.
well, especially with you, with our surgeons, as to, what we're doing here and how we're doing it.
Exactly.
Dr. Schultz, is it hard to do? I mean, what drives whether someone, I know, a loaded question again, you're allowed to tell me you're not answering it. What can everyone have reconstruction at the time of mastectomy?
Probably not. I think in many cases, the pathology, the final diagnosis can and should be established, because the implications after surgery are that a patient may need to have aggressive chemotherapy, adjuvant, postoperative chemotherapy. The patient may require radiation treatment, either to the chest and or the axilla where there's lymph node cancer. And all of that information has to be inputted before saying we should do immediate reconstruction. It's a gift to be able to do immediate reconstruction, but all these little technical criteria have to fit in place. Many times the stage of the cancer is unknown, and plastic surgeons are very protective of their work and nervous about infection. And that would sometimes prohibit immediate reconstruction, but in many cases, immediate reconstruction can and should be done. It's a very individual, complex decision matrix.
Well, thank you for that. I think that's important to know. What haven't I asked? What is it that any or all of you like your patients to know about? They have a diagnosis of an early stage breast cancer. What do you want them to know as you start to work with them and consult?
So, about adjuvant therapy, there are many more things to be said. Patients that have hormone positive disease, estrogen positive, they do need to stay on their medication. And I know that many patients give up. And it's interesting to see people that went through chemotherapy, they give up on the hormonal treatment.
That's the oral medication
Yeah.
we're talking about.
Yeah, so the aromatase inhibitor, there is a duration. It's minimum 5 years. And I say minimum because not everybody is the same. So nowadays we do have other tools based on which we decide who needs beyond 5 years of treatment. So that is something relatively new. The other thing that, again, this is individual. The other thing that is relatively new, patients with BRCA gene, BRCA1 and 2, not other genes, there is a medication that now we may recommend right in the adjuvant setting, particularly patients triple negative disease, estrogen negative, and that it's something to be discussed with these patients because it makes a difference in their survival, actually. So that is new. That medicine is called olaparib, but again, it's only for BRCA1 and 2 patients.
Mhm. And what's it called again, Dr.
Olaparib.
Lapalid.
Olaparib.
I'm not very good at these names. I know.
Yeah, and I can't tell you the brand name.
I know you do. Thank you
That's
so
right.
much for that. Anything else, Dr. Schultz, you'd like to?
I do. I think we're winding down,
We are.
and I have a very strong plug I want to amplify, and that is to get screening mammograms and to get physical examination of the breast, both together. The mammogram alone is insufficient for screening, and the physical exam alone is insufficient for screening. And because I see the back end of patients that have had a problem, and our team, our other surgeons see this back end, all the effort needs to be done upfront for screening. Screening is so important because it's such an easy disease to treat. It's so easy to perform good outcome and have surgical cures if this is detected early. And early detection means physical examination, self-exam, and examination by your primary care doctor, your family practice doctor, your internal medicine doctor, your gynecologist, coupled with the mammogram. And we're so happy when we find an early breast cancer, and we're getting down to getting diagnosis of breast cancer 5 millimeters in size,
which is
4 millimeters in size. And last week we had a 3 millimeter breast cancer, invasive cancer. So the imaging technology is there. The best outcomes are early diagnosis. And that's true for colon cancer. That's true for skin cancer,
lung cancer
screening. Our healthcare system should be incentivized and directed to direct patients for early diagnosis. And then everything is a lot easier and the choices are better.
Agree 100%. Good plug.
Yes.
Yeah.
Dr. Schulz.
The
Thank you.
same goes for survivors of breast cancer. You know, for survivors, patients are quite surprised when I say that, oh, what do I need to do? Nothing is mandatory. The only thing that really is mandatory to have breast imaging and an exam. Everything else, you know,
I hear
but the exam part is something that gets skipped many times.
Dr. Lingareddy, anything else you'd like to
Yes.
add? Okay.
Not to be afraid of radiation. It really is changed. The technology is just unbelievable. And we are blessed to be in this community and have the equipment that we
We do.
have to protect the heart, protect the lung. Our TrueBeam machine monitors the patient's breathing. We do something called breath hold to protect the heart. So radiation has really evolved and changed over the years and continues to. So not to be fearful of the technology.
Good advice. Heather, do we have any questions that have come in?
Great information. During the span of time between diagnosis and treatment, what can the patient do to enhance the post-op outcome? What kind of support is available?
Support systems.
Well, I guess they're looking at me. So thank you so much for that. As an oncology social worker, I will jump right in on. We are very lucky to have a breast cancer information and support group. I am privileged to facilitate that group and have done so for about 21 years, with many of the providers sitting next to me joining us in that group, ensuring that we're sharing good and helpful information. We know from the moment you hear those 3 words, you have cancer, your stress level goes from here to here. That's normal. We get that. We have ways to support you, to educate you, to walk you and navigate you through that experience. We have an oncology nurse navigator. Her name is Abby. She co-facilitates the breast information support group with me, and she has over 20 years experience as an oncology certified nurse. We have a lot of supportive care for you. And at Eisenhower and Eisenhower Lucy Kirchie Cancer Center, we are the only nonprofit facility in the Valley. That means our programs are open to our community. So while we want you to be treated by us, look at how fortunate we are. No matter where you're treated, if you reside in this Valley or you are visiting us in this Valley, you are welcome to our supportive care program. So I think that's very important. Thank you for that question.
From a surgical perspective, additionally, there's just practical tips, and it's self-evident. Take care of yourself. If you're smoking,
gonna say.
You probably won't be able to stop smoking, but you can cut down significantly. If you're drinking alcohol more than 1 or 2 glasses of wine per day, cut down. All of those maneuvers improve your operative risk and enhance your recovery. And Hippocrates said walking is the best medicine. All of us need to get up and walk some more. And all of that helps recovery. We need to be physically active.
Yes, and we do offer smoking cessation program. I'm going to provide that information at the end as well. Thank you for that. We have another question, Heather.
Yes, next question. This patient says, Dr. Schulz did my lumpectomy on 2/2 of 2022. I had 4 lymph nodes tested, but no evidence of cancer. My margins were clear. I had 4 weeks of radiation after that. Why is it now that I need to take Arimidex? I have fibromyalgia and I am in so much pain.
Dr. Popescu.
So basically, that is a very common question. Once, and I'm gonna say again what I always say, once you do your surgery, you're cancer free. Everything you do after that is to prevent the cancer from returning. And there is enough research and statistical evidence to recommend aromatase inhibitors or tamoxifen to women that had estrogen positive cancer. We know that everyone's risk is different. So I don't know about this particular patient, but basically radiation and medications do different things. Radiation, it's given to decrease the, to increase the local control, meaning where the tumor was. The medicines go after cancer cells everywhere they are, microscopic, anything left behind. Aromatase inhibitors, if someone takes it for 5 years, they decrease the risk of cancer by roughly 50%. Tamoxifen by 40% of whatever that risk was for that particular patient. Everybody's risk is different. Obviously, not everybody can take it. Side effects are there. However, sorry, aromatase inhibitors, you know, what I try to do is, okay, you have side effects, you stop it. And after a while, you try a different one. There is 40% chance of that second trial to be actually beneficial and better for that patient. It's a matter of trying.
Doctor, is there a time that they could take it as well? Maybe in the evenings?
Right.
That helps?
Yes. So many times, you know, it's the issue of hot flashes mostly. So what I recommend to patients is to try to take it at a different time of the day. The time doesn't really matter. Everybody finds their own time as long as you keep it at the same time of the day. So in other words, if you take it in the evening, try it in the morning. Maybe your side effects will be less.
And you can switch them then, you're saying, in a discussion with your physician?
Yeah, of course.
Great question. Thank you.
Okay, next question. Is there a test to see if my ER positive and PR positive have gone down?
I'm not sure I get the question, but the ER and PR positivity, it's tested on the tumor, on the cancer. Once the cancer is gone, there is nothing else we can do. And I do get this from patients, yes, blood tests to check the hormone levels. We don't go by that. It doesn't matter. At menopause, you are expected to have low hormone levels anyway. That's like a false reassurance, if you want to call it like that. So in other words, no.
I have a response because I get this in the office even as a surgeon. And I think a lot of patients are looking forward to getting a tumor marker a blood test to show the cancer is gone, stayed away. And they often compare it to perhaps a man who has prostate cancer and they get their PSAs. Or they'll compare it to a woman who had ovarian cancer and has serum testing of the CA-125 to see what the level is. So those hormone receptors are what we call a report card on that cancer, but it's a static report card. The cancer was graded and it's been removed, and there aren't any further hormone level testings that are helpful to determine whether or not cancer has recurred. I hope that's helpful.
I know tumor markers and questions about them can be frustrating at times for physicians.
Yes.
Patients do feel, well, just do my tumor marker and then we'll know if my
Right.
cancer's back.
Right.
Yeah, and that's not the case. It's just one of many things you might look at to
Yeah.
help you may have a big picture of what's going on. Is that it?
Yes, so also, you know, what I would like always to find out from the patient, how anxious are you about that? If there is someone whose anxiety is off the charts, just by reading a number, it's not the best way to monitor it, because tumor markers, the way I explain it, you can draw that blood test every single day, it's going to be a different number. So as long as it stays in a certain range, some people baseline it's high, but that's how they are. So we don't go only by one elevation and panic. It's not that. I found during this pandemic a lot of issues with the tumor markers, and I think it's not only about the cancer. I think there are other circumstances. So once you find a tumor marker that's high, you wait a couple of weeks, repeat that, don't panic over it.
Mhm.
Some people can handle it, so it's better not to even go that route.
Next question. What is the CTS5 calculator?
CTS,
C like cat, T like Thomas, CT5.
CTS5 is
Are we
what they type.
talking about the circulating tumor markers?
Maybe.
If that's what it is, that first of all, it's still experimental for early stages. It's a test approved for metastatic cancer, where we know more or less the disease status in between doing other tests. For early stage breast cancer, that doesn't have a role, because there is really nothing we can do. Early stage, we know if you do that test, yes, it may mean it's a chance the cancer may return sooner, but it's nothing we can do about it. There is no treatment approved to deal with that. You don't start giving chemotherapy just to prevent something you don't have down the road, I mean.
Right.
So, yeah, if that was the CTS.
That's all I have.
That is your question? Well, I would like to summarize in a few ways. One, certainly by sharing, and thank you for that focus on prevention, especially post or still in COVID times, when many people were afraid to follow up. They didn't want to be, thank you, Aaron. They didn't want to be in a healthcare setting or in a hospital. It was frightening to them. They didn't want to come out. Maybe they didn't feel well. Well, that's past mostly. You can come out safely, mask if you need to, social distancing. Do not give up on your preventative screenings. They are the key to catching something like cancer early when it's treatable and most often curable. And to that end, I will plug the fact that Eisenhower, to expand access to mammography, has Lucy Curci Cancer Center has now opened up sometime late fall, early winter, a breast cancer screening department in Palm Springs on Sunrise in our Eisenhower building there. We are very fortunate. The Ann and Kirk Douglas, for those of us that are older, know the great actor Kirk Douglas. Their family foundation helped support us in opening that breast center. This will expand screening for all. The important thing is to get screened. That's what we want you to walk away with. That's very important. And lastly, to share with you that our physicians here are part of larger teams, and we are very lucky. Dr. Schulz works within a group of surgeons, Dr. Popescu with a group of medical oncologists. Dr. Lingareddy has really expanded our radiation oncology department. We now 3 full-time physicians. We are growing all of the time. We are here for you. They are the experts. We are fortunate indeed to have this team taking good care of us. So we remind you, get screened, be vigilant, and please take care. And thank you for joining us for this presentation today.